Would it be easier if she was over there for your frame?
Sure.
Oh dear.
We're new at this.
We're just gonna be rushing.
The less editing, the better, because I don't know what I'm doing.
Keep me a little fresh.
Okay, lunch is out there. We're just waiting on a few more items that didn't like go without order. So if you guys want to get started, they're delivering
Send it
it.
back?
No, they called. There's drinks right over there, and we'll get started with introductions and get started all together. So we'll start with Dr. Levy.
So I'm Sharon Levy. I'm the director of the Adolescent Substance Abuse Program at Boston Children's Hospital. We are a center with 4 main components. We have a big clinical program. We see about 4,000 kids for evaluation or treatment of substance use problems, disorders every year. We have a big teaching component. We have SAMHSA-funded project. You'll be seeing the results of our previous SAMHSA-funded projects on the materials we've created. And of course, we have a partnership with JSI and the New Hampshire Center for Excellence through their work with Hilton. We also have research component. So I'm going to be showing you just very little snippets of some of the research we've done that's helped to inform what I'm going to present to you today. And then finally, we have an advocacy component and really trying to get, really our primary goal of the advocacy component, well, our overall mission is to reduce the harms of substances on children and adolescents, but our primary goal is to get more treatment out to more adolescents.
Amy.
I'm Amy Putnam. I'm with the Center for Excellence, and we are providing technical assistance around ESPER implementation to the charitable foundations sites in New Hampshire. So we've been very closely working with Lindsay and the team here, who's been trying to figure out how you guys are going to do this with the young people.
Dr. Rose,
Sandy,
just go around.
I am a technologist and the behavioral health director, and today's Wellness Wednesday, so we get to our jeans. Our wellness shirts, everywhere our wellness shirts.
I'm Trudy Trophy, I'm PA, so primary care.
I'm supporting on an LICSW.
Melissa Sylvie, Director of Public Health and Prevention. Hopefully, shortening my title a little bit. And I actually wrote the grant.
Oh.
The funding it.
This was Dr. Thompson, he's on our team. We have some Kevin's at Kevin Ducks here. And then we have
2 more mid-levels.
Diane Bernard,
PA.
and Crystal Bernard.
Okay. And are there any pediatricians here?
No.
No? Okay.
Now, we do a lot of PA.
Yeah.
Okay. I have a lot of slides. I don't mind editing if you want to start late, but we could just get started and have people jump in.
Sure.
Okay. So thanks for having me. I think this is going to be fun. I'm going to start with a case. So this is Trevor. He's a 17-year-old boy who's coming in for an annual physical, and he's doing well. He's a B+ student in 11th grade. He's a 2-sport varsity athlete. We talk about alcohol, and he says he drinks occasionally, with friends on the weekends, and he denies illicit drug use, and he's starting to look at colleges. So his primary care physician assesses him as low risk because his drinking is pretty occasional and it's social, and he seems to be doing well in school and in sports. So since we're a very small group, yes, no, good, like low risk drink. No? So, why not?
Well, it's still underage for one
Because he's
thing.
17.
And so I think our desires for no drinking at that stage, right?
Good guys.
And just because he's doing well, it doesn't really mean anything.
All right. So thank you very much. Perhaps anticipating given the topic of the presentation, here's the epilogue. So 1 week after the appointment, Trevor attends a party, and he has a couple of beers, like he says he usually has. And while driving home, his car jumps the curb and slams head-on into a tree. And he's pronounced dead at the scene, and his blood alcohol concentration is 0.4. I'm sorry. I know it's a gruesome case. It's not. It's fictitious. But although we did kids who ultimately gone on to car crashes, The reason I just want to get everybody's attention, so often kids like this will be screened as low risk and people will move on, right? But that's really not what we want to do. So I just wanted to make a couple of points with the case. First of all, there is no safe level of drinking for adolescents. That's number one. Number two, drinking by older teens, it's very common, and the people around this table are not going to stop all of it. I want to acknowledge that up front, but at the same time, by failing to give clear health advice not to drink, we are missing an opportunity. And that did not happen in this case of Vignette. We don't know what would have happened if he had gotten clear advice, but it didn't happen. And then finally, and this is what I want to spend most of the session on, but the case vignette did actually not provide enough information to accurately assess Trevor's risk. As you said, just because he's doing well, we don't really know. Smart kids and high-functioning kids from high-functioning families, they can actually look pretty good and still have some pretty serious substance use disorder. So that is a very, that's a screen that lacks sensitivity if you're just kind of using clinical impressions like that.
So could we pause here and have everybody grab their lunch?
Sure.
It's all set and warm, and it's right outside the door.
Sure.
And that way, we won't have to interrupt the rest of the training. Is that all right? Sure.
Always all right to eat.
It's all right to eat.
Always all
All
right.
right, I got Chinese food. All right, so let's do it.
You guys have a plan.
So we have to grab you, we have appetizers, plus we have vegetarian.
Yes,
Some of the veggie.
That's what I
Yeah,
heard.
yeah,
She
yeah.
employment
Stuff down.
contract.
I'm moving around your
So-
table.
A little bit of,
Are you sure you don't
yeah,
mind?
not at all.
Thank you.
No problem.
So this is grabbing something for
I'm
me.
not
Oh,
sure.
so you took an order.
Oh, it's so
hard.
in order.
Yeah, why not go to
Yeah, she just said she's ready.
Yeah, how long can you get her to do that, by the way? A little while longer, right? I forgot which mountain you were on when you were hiking, because my husband and I were hiking this weekend. I was thinking-
going to Belknap Mountain.
Belknap, yeah, I don't think I've ever been there. I was thinking about that when we were out hiking, it's like,
Yeah,
so easy to slip on the leaves going down the hill.
One of the physical therapists that I went to, she went hiking and had a bad fall and got contusions on her knee and
Just recently?
yeah, some pretty serious bruising, but not seriously injured.
Well, you have water,
I
yeah.
got water.
What was I gonna say about that? When we hike, I'm always really thinking a lot about that whole thing about how do you prevent it, but from falling, because people do fall and they least expect it, but we just were doing this hike and hadn't been out since the leaves had come down. Campus, no matter what you have on your foot, would dry on the top and slide on the rock. And you had to like walk around them, try to find ways that were soil, where you were getting on dirt and rock, and you couldn't, it wasn't perfect by any means.
I've taken some serious headers.
I never broke it all.
Yeah, I've definitely taken. I've hiked Mount Washington in May when there's been like 3 feet of snow, and with the they're not
Crampons, what are they called?
Yeah, they're really the crampons that really have kind of like the teeth.
Yeah.
But I think hikes like that, you tend to be more cautious
Of
and
course
pay
you do.
attention just
Yeah.
because of the terrain and the type of hike it is where, this was really some of our challenges.
So, is that up one day and back down one day, or did you have to stay?
Mount Washington?
Yeah, do you stay in a cabin?
Yeah. So right at the base.
But you hiked it in one day and back, meaning it is a one-day hike? I always thought you had to, that
We
Mount
stayed over
Washington
once and one day we hiked out. Yeah. So did both.
But you can go up and down in one day.
Yes,
I
my
was
middle
convinced
son
that
was
we
bar
can't
mitzvah
do that. I
and
said,
it
no,
was
I'm pretty
planned.
sure there are different trails.
Yeah, you can.
I said, well,
In
you
our
can
backyard, well, we
possibly
live in a
start
condo,
with
but in the
walk
courtyard
or
of the building.
Oh, really? You have somewhere where you drive to?
Like 14 hours.
It was June, we
Well, that's
risked it
probably
because
longer.
at the last minute I canceled the tent,
The Lake of the Clouds is
but we got it, we lucked
It's
out.
right at the
Right,
base.
you heard the weather
So-
report.
On 16?
Yep, as soon as they put the weight, 48 hours I have to cancel
The
it.
Crawford Trail.
I
Okay.
did, it was a
You hike
little
the
warm,
Crawford
there was a
Trail
little
up,
too much
and
sun, but
it's probably
we have a nice
7.5,
shady area for
8
people to
miles.
sit
And
and
you
break,
stay
or,
like in the clouds, they kind of
you know,
there.
these
Oh, and then you
bar
keep
mitzvah
going.
services with my rabbi can be very
You
long.
stay in the top.
So
then
it's
come down the
totally
whole way.
fine if you're holding it up, I take breaks.
I mean,
Still a good substantial
rustic.
hike.
I mean, it's a
Oh, yeah, that's fun though. I bet that's fun.
So it's kind of
Cool.
Hungry?
No, I did 4. My daughter's was 4, but his was on a Thursday, so it was like only 3.
Now it makes a big difference. How many people?
Had about 150 people.
feels okay.
Bagels and lots from Costco, well, lots from Costco and bagels from Lowe's, you know, it was really good. It was one thing.
There's not, actually, I just did training. Big banana.
Lots of swell.
But the thing is, he was thrilled, he had all his friends from school,
Yeah, but
and
I couldn't even get my
was
foot
great.
issue with the breakfast, but it's on there, so.
Your door is shut out there.
It is?
I thought you were coming to see you.
What's that? My door, my shoulder.
Yeah, so I thought I went by and said, she doesn't be coming out.
Oh, no.
Yeah,
Is everybody okay on your end there?
yeah.
Everybody survived?
Yeah, she let you fell. Oh, we fell on the floor. This morning. Oh, yeah, oh, patients. So we sent her to the emergency room because her brother foot hurted. Yeah, she did some driveway.
Diane Payne for Dollars, she's our PA.
Hi, nice to meet you. Can somebody just let me know when I should start again? I think people will be
I would say no.
No? Okay.
I'll treat you.
Melissa,
The
come
party
back.
begins.
All right, Trudy's here, it's all good.
Sorry, should I wait till I get there? Come back. Melissa?
Okay, Sue, and I hope I did okay.
Okay.
Now we're ready to.
Okay, great. So picking back up. So the first point that I want to make is that alcohol and drug use are more dangerous for teens than adults. I think a lot of, since this is not the issue around this table, but a lot of parents that I speak to and even providers will say, you know, what's a little bit of drinking? They're really kind of thinking about their own drinking, and they're not the same, they're not equivalent. Here's why. Adolescents are not little adults. I'm going to show you some brain development slides. Sometimes I call this neurobiology for non-neurobiologists, but really what I mean is neurobiology by a non-neurobiologist. I'm not a neurobiologist. But in a very simplified form that I can understand. So this is an image of a brain. This is a brain of an infant, and you can see that it's pretty sparse. The neurons are not densely packed. There are not a lot of connections between them. And what happens as a child or an animal gets older, in the first phase of development, we call the process blossoming. And so you get a lot more neurons, and you also get a lot more connectivity between them because each neuron starts sending out lots of these connections to other nearby neurons. And so you get this densely packed kind of brain. And then after that, you actually, in the next phase, you actually get a lot of pruning. So you know, when I learned about this, I got very depressed. I thought,
Or down over here.
yeah, exactly. Like, 'cause this is the brain of a 6-year-old, and there's all those great neurons over here. And then, you know, by the time you're 14, you've already started losing them, right? Well, it turns out that this is a normal maturational process, and you actually do. You think you never want to lose brain cells, but you do. You do want to lose them, and here's why. This is the ideal brain configuration for learning, right? So, you know, the younger kids who say they learn things really quickly and really well, that's because they can call upon all of these interconnections to learn new things and to kind of hold them. But this is a much more efficient configuration. So what happens between here and here is that the connections that are not used actually get clipped away. The connections that are used become kind of super highways, and they get covered in myelin, which insulates these nerve tracts and makes signals go really much quicker. And so, you know, that's the difference between, you know, a 6-year-old and proficiency, right? Learning and proficiency. So that's really what's happening. This does not happen in the same part of the brain at the same time, right? There's in fact an orderly progression from back to front, right? If you're interested in this topic, you've seen this slide before. This is probably the slide that, you know, you can see it. I've seen it probably 100 times in presentations, but it's looking at brain development. So green is relatively undeveloped, blue is developed, and you can see that, you know, it starts in the back and kind of progresses forward. So by the mid-20s, you know, the process is pretty much done, and you have a mature looking brain. But for me, because I'm a developmental behavioral pediatrician, I'm really interested in, well, what's happening in the brain and how does that translate to the actual kid? And it's really fascinating to put those two together because, you know, the action in the very first years of life are really, it's all in the cerebellum, the very backmost part of the brain that's responsible for physical coordination, sensory processing, right? But what is the kid doing in the first 2 years, right? What do we call an 18-month-old?
Toddler.
A toddler, because that's what they're doing. They're becoming proficient at walking, right? And then when we look at the preschool years, the action is really mostly centered around the amygdala, which is responsible for emotional regulation, right? And if you think about it, you know, you're going from a 3-year-old who cries to communicate and tantrums to ultimately a school-age child who's really going to hold it together much more, right? So that's where the development is there. Now, in the school-age years, there's a lot of development in the area of the brain called the nucleus accumbens, which is sometimes called the brain's reward center. This is a really important area for addiction, so keep it in mind because it's gonna come up again. But this is part of the brain that's responsible for motivation, right? And in the school-age years, you know, that's where you really see kids like kind of striving and wanting to do well and wanting to master tasks. You know, that's typically the focus of this time of development. And then finally, the part of your brain that is responsible for what we call executive functions, like planning and organization, that's all centered in the prefrontal cortex, the part that's really closest to your forehead. And that develops last in adolescence. And
I've never got
well, you know, and it's interesting because you think like, well, so you've got this period of imbalance, right, between pre-adolescence and adolescence, where you've got this nucleus accumbens, which you can think of kind of as a behavioral gas pedal, fully developed, and no brakes, right? And so, you know, you could speculate evolutionarily, well, why would that be? And, you know, if you think about it, thousands of years ago, we needed the youngest, healthiest, strongest part of our population to do things like hunt and keep away invading tribes. And so, you know, having a part of the population that's going to act before they think was probably not a bad idea, right? There are certain things you just can't really convince adults to do. Chasing after, you know, a wildebeest with just a stone is one of them, right? But you want somebody who's able to do that. So you know, it was evolutionarily advantageous, but we don't chase wildebeests anymore, and yet adolescents are still looking for ways to stimulate that nucleus accumbens, and so some of the best ways available to them are really through drugs, all of which, although they have lots of different actions on the brain, all of which end up in this final common pathway where they're directly stimulating that nucleus accumbens. So adolescents are absolutely driven to do towards stimulation, and they're driven towards drug use in this kind of way. That's really one way for them to fulfill this natural drive. It's an unhealthy way, but it is the way that we as a society have made available to them right now. Here is a really interesting, complicated but interesting experiment. I think it's really very elegant. So here experimenters took people of different ages and put them in an MRI scanner, and they had them do a simple task, and then they gave them a reward, and they looked what happened in their brains, okay? And so on the left, here, we're giving a very small reward, okay? So here's the arrow, you do the task, and then we look over here, what happens when we give a reward. So I'll actually start with the adults. So the adults are this green line, and when adults get a small reward, they make a small response. That seems perfectly reasonable, right? This blue line is little kids. So if you give a little kid a small reward, look how much activation you get. Now, I'm a developmental behavioral pediatrician, so how many times have I said to a parent, just give your kid a sticker? That's all that they need, because even very small rewards make very big activation in the brain. Now, here's the really interesting thing. This black line, this is adolescents. They get a small reward, they actually deactivate their brains, okay? They're actually, they don't like these small rewards, right? How many people have heard an adolescent say, oh, Mom, that's so lame, right? I mean, that's really what they're talking. This is actually, it's behavior, but it's predictable behavior. It's driven by the neurobiology. Look over here, this is the same group of people getting a large reward for the same task. So again, start with the adults in green, small reward, small activation, large reward, large activation. Adults are rational. Look at the kids, the little kids. Small reward, big activation, big reward, big activation. It doesn't matter. Don't buy your kids big rewards for, a sticker will do just fine. But look at your teens. Small reward, deactivation, big reward, huge activation. You can see this is going to drive behavior, and kids are really going to do these extreme behaviors, which we know, because we know we've all seen adolescents. We know that they do that. So I showed this slide once with my son, who's 13 years old. He was in the audience, and I just meant to say, oh, look, there are certain things you can't get adults to do. But before I could get a word out, he said, I put this slide up, and he said, oh, that's so cool. And I thought, actually, this is just like a living demonstration, right? So now I have a question for you. I mean, thinking about behavior, thinking about how behavior is driven in adolescence, this should be perfectly consistent, but anybody want to guess what % of all alcohol consumed by underage drinkers occurs in the context of a binge?
80.
It's close to it. It's like actually 90%. But it's essentially all of it, right?
Yeah.
I mean, it's essential. So when kids drink, they binge drink. So there is no safe consumption because kids don't really drink like that, right? That's number one.
Can I go back to that slide with adults? With the adults with a large reward, was that also counterproductive for the adults? Is that
No,
okay?
it's totally
It's
relative.
the large reward.
Small reward, small response, big reward, big response, but all positive.
All positive.
Mhm.
That was after the reward.
You actually have to look in this. I mean, I'm not a neuroscientist.
Well, I was just very curious because we did an incentive. I knew that's where you were going with this. And, so it did plummet after the reward was given.
So the data certainly further justifies an incentive program?
Until it's taken away. Until it's taken.
There's a lot of data.
It did go up.
That's why it needs to be institutionalized.
Oh, we can, I thought it did.
Should go back to the
Is it?
Right.
So the fact that kids binge, it's not the only problem. The second problem is that, because their brains are different, when they binge, they're actually less sensitive to the motor impairing effects of alcohol. So, you give an adult a couple of drinks and they curl up and go to sleep, but not the adolescents. They actually become like a little bit more socially engaged, and they're more likely to do things like drive a car, have sex, all these things that we really would not like them to do while they're so impaired. And so this is another reason why kid drinking is not equivalent to adult drinking. And so I love this cartoon because it was drawn for me. And so it says, don't cross anatomy, me, young lady, you can't go drinking until you're mature on a cellular level. Okay, so the health impacts, actually it might be better for me to do this. So the health impacts of alcohol and drug use on kids, they're both acute and chronic, and the acute problems, any kid who drinks is at risk of the acute problems. You don't have to be a long-term drinker or drug user to have any of these problems, and we know what they are, right? Injuries, overdose, et cetera, et cetera. But they're real and they're serious and they're a big cause of morbidity and mortality in this age group. In fact, look at this slide. It's a little old, it's from 2009, but I can tell you nothing's changed. The top 4 causes of mortality in the adolescent age group are motor vehicle crashes, other intentional injuries, homicide, and suicide, all completely preventable. They account for 3/4 of all deaths in this age group. This is an otherwise healthy age group, and when they do have mortality, it's because of behavioral problems. Every single one of these problems is tightly associated with alcohol and drug use. So even a little bit of substance use is putting kids at very significant risk. And then beyond that, some kids go on and they continue to use, right? And then we have problems like brain damage, learning problems, psychiatric problems, and alcohol and drug dependence. is an older slide using the older terminology, but that is, oh, I'm missing the slide. So it is also the case that the earlier you start using your substance, the more likely you are to become addicted to it, right? So kids who start to get drunk for the first time before they're 13 have a 50% chance of developing alcoholism, whereas you can decrease that to about 9% by waiting till age 21. So, every reason to have kids delay, decrease, not use. But in terms of the long-term consequences, so this is, anybody know what this is? Yeah, that's alcohol. And I don't know, you may or may not remember high school chemistry. It looks like water. I'll just tell you, it looks like water. To your body, it looks a whole lot like water. Alcohol, there is no alcohol receptor. Alcohol is freely permeable to cell membranes, and it has its impact both intra and extracellularly, including directly on the DNA in the nucleus. So it's got lots of different effects, and it tends to have different effects on different people. I think we all sort of know that. But it's true because it's just this molecule that can kind of get everywhere, and so depending on your individual makeup will depend on what it will do to you. But one thing that's fairly consistent is this is a part of the brain that's called the hippocampus, outlined here in blue, and this is a part of the brain that's very important for memory and learning. Okay, and alcohol is particularly toxic to the hippocampus. So you can see here on the right in red, we have healthy kids, non-drinkers, and on the left we have kids with alcohol use disorders. So these kids have been drinking quite a bit. And you can see there's a range in the normal size, but this curve is shifted down. These hippocampuses are smaller, and that's a statistically significant finding because alcohol is actually damaging the cells in the hippocampus. Here's another neat experiment. So in this experiment, this is Susan Taper. She's out in California. And
quick question about that.
Yeah.
So, do you know, as far as whether do you have sort of MRIs like before and after that show that it's some damage, or is it that people with that are in the lower activity?
Yeah, so is this an association or causation? This one is actually, this is Susan Taper as well. This is an association that, however, the NIAAA has put a huge investment into following kids longitudinally, and I can tell you that they have data that I'm not showing here that mimics this.
Sure.
So, again, this is, sorry? Yeah, this is a PET scan. So this is looking at brain activation. So this is a kid in a scanner and asked to do a task that involves memory and concentration. And so this kid these are both 16-year-olds, okay? And you can see here that on the left we have this a kid who's a non-drinker asked to do the task, and she's using this part of her brain. Now, we had also in the scanner a kid who was a heavy drinker, so these are different kids. She's doing the task, and she's doing it just about as well. I'm not showing you the results of her task, but she's doing it just about as well. But she's actually using a lot more of her brain to get the task done. And this is a sign for neuroscientists that there's a problem here, that to accomplish the same task, you have to actually recruit more brain centers because some of the brain centers aren't working that well. This is the same experiment repeated with 20-year-olds. So this is a non-drinker. It's actually a different task, but you can see that this task requires a lot more brain. This is a 20-year-old who's been drinking heavily since adolescence, and here we have quite the reverse. There's very little activation in this brain, and it actually turns out the performance is much worse of the heavy drinker. So it seems like for these more complicated tasks, by the time drinking has been going on for a while, they can no longer compensate, and performance starts dropping off. And this is also true in regard to what we see in school performance with kids with heavy alcohol, heavy marijuana, heavy drug use. They don't do as well at school. They don't have functional outcomes that are nearly as good. And part of that is because there's actually damage to parts of the brain that particularly the hippocampus. All right, so moving on to my favorite substance du jour, marijuana, because it's all over the news. So this is THC, this is tetrahydrocannabinol. This is the molecule, the active ingredient in the marijuana plant. Okay. This is anandamide. This is an endogenous ligand. That means that this is a molecule that the body makes that binds to the system, right? That your body's series of receptors. This is really just mimicking this, right? So it looks enough like this that it's fooling your body and binding to the receptors that are really meant for this, okay? And it turns out, this is really fascinating. So these little purple dots are areas in the brain that have a high density of these cannabinoid receptors. And I find this slide really fascinating because you look at it and you're like, wow, they're all over the place. Well, they are all over the place. So I can't really understand why this receptor wasn't even discovered until the mid-1990s, given how numerous it is. But that's just the truth. That's really where the study of cannabinoids begins, because it was just really unknown what was happening in there before that.
In our THC and cannabinoids, I thought they were sort of different chemicals that are in the marijuana. Are they?
So cannabinoids refers to any molecule that can bind the cannabinoid receptor. THC is just one of many. And you are correct. Marijuana has over 100 of different cannabinoids that can all bind, but THC is the one that's most psychologically active, and it's the one that breeders will try and increase the concentration, right? It's most directly related to the pleasurable effect.
I heard them called breeders.
I just want to point out that this is the brainstem, this is the part of the brain that controls breathing and heart rate, autonomic function. Really no purple dots here. And for this reason, you really can't overdose on marijuana. You can, actually, but lethal overdose is very unusual. I mean, if we looked at opioid receptors, they'd be all over here, right? Because it plays a big role in controlling respiration. So it makes marijuana relatively safe in overdose, and some people use that as try and explain that marijuana is safe because of that. But I just want to tell you that if I were showing you nicotine receptors, you wouldn't see any here, and you really can't overdose on nicotine either, but that does not make cigarette smoking safe for health. So there's more to think about than just overdose. All right, so this is a picture of a neuron with the cannabinoid receptors here, and what happens when endocannabinoids bind, what happens is, I tried to animate this, let's see. Yeah, so when they bind, what happens is you actually get decrease, you get a blocking and release of these messengers from the cell terminal that communicates with these other cells. Okay, so it really quiets the cell down. It stops the cell from sending out messages. Cannabinoids are really fascinating because they actually have impact on both the dopamine pathways as well as the serotonin pathways. So they're really pretty non-discriminate. They tamper cells down in all of these pathways, and obviously they're involved in many regulatory functions of the body. Okay, this is a very important molecule for homeostasis. Just like with alcohol, the hippocampus is particularly sensitive to THC. So as it does in other parts of the brain, THC will reduce hippocampal neuron activation. And with chronic exposure and chronic tampering down, some of these neurons will be lost to continual suppression. And just like with alcohol, chronic marijuana users have smaller hippocampuses, poor memory, and functionally, again, I'm a developmental behavioral pediatrician, they tend to do worse in school and have worse life outcomes. And that is really very well established in the literature. I don't think that there's any disagreement, any reasonable disagreement about that. Here's one study that got a lot of attention at least 2 years ago. It is a longitudinal study done in New Zealand. And basically what they did is they recruited a cohort of kids at age 13 before they had started smoking marijuana. And they followed them over time. So they re-interviewed them at 18, 21, 32, and 38. So really followed them for 25 years. And every time they caught up with them, they asked them about their drug use, they gave an IQ test, and they did a whole battery of tests. And what did they find? Well, that if you look at IQ, these are the individuals who never used marijuana in all of that time. Their IQ stayed exactly where it was when they started. But if you look at the kids who were marijuana dependent using the DSM-4 criteria 3 or more times across this longitudinal span, they actually dropped their IQ, and this is statistically significant. They dropped from about 100 to about 94. So it's like a 6-point drop with heavy marijuana use. Now again, this is a longitudinal study. This is still an association, and some people will say, well, yeah, but maybe it's something else that causes you to drop your IQ and to smoke marijuana, and that's possible. Although, if you look at this, you're seeing what we call a dose effect. And so the more marijuana, so these changes, this is just kids who used marijuana but never used heavily. These are people who used heavily but then stopped pretty quickly. These are people somewhere in between. They used rather heavily for a while and then stopped, and these are people who used heavily all the time. And you actually see a dose effect. Okay, and so we're never going to be able to do randomized controlled trials on this. This is illicit drug use. We never do that. But this kind of dose effect is really suggestive of an association, and is actually very hard to explain away today.
And it's not reversible, right? So when they stop, it goes
So that's right. I mean, so the critical period is during adolescence. There's more data from the study that I'm not showing you, but people who started smoking later, even those who used fairly heavily, didn't have these big drops. But it's not reversible. I mean, once it's there, it's there. So, in addition, regular marijuana use during adolescence increases the risk of developing psychosis, schizophrenia, anxiety, and depression in adulthood, all kinds of bad things. This is the most striking effect is with thought disorders, which are fortunately rare in the population, yet look at this. So this is a study done with Swiss recruits, okay? And they basically looked at the entire population. They figured out how much marijuana they used, and then they figured out an odds ratio for developing schizophrenia in their lifetime, okay? So these are, or actually with schizoaffective disorders, a thought disorder. So there are roughly 45,000 recruits, nearly 40,000 of them, and so Switzerland's doing pretty well, because nearly 40,000 of them didn't report any drug use at all. And so this is the odds ratio here is 1. That's the comparison group, right? Now about 5,000 of them had said, yeah, I've used marijuana, but less than 50 times. Okay, so it's like occasional use. Their odds ratio for developing marijuana looks like it's about 2, but when it was adjusted, it falls to a non-significant difference. These are the people who used 50 or greater times. There were only a handful of them, but their odds ratio for developing a schizoaffective disorder was 7.4. They were 7 times more likely to develop schizoaffective disorder. And so, this is a really impressive odds ratio. Now, when you think, well, 50 times, yeah, that's a lot. It is and it isn't. If you've got a kid who smokes about once a month through high school for 4 years, do the math.
And again, with this one, what's the evidence as far as whether this could be just association versus?
So, the nature of these studies is that they're all associations. However, this is controlled for all of these things on the bottom. So they controlled for whatever possible confounders they could think of. Because it's not randomized, that's the problem with non-randomized. You can control what you can think of. You can't control what you can't think of. And so, that's an issue.
So you couldn't necessarily control for people that, were schizoaffective and were using marijuana to try to treat their schizoaffective symptoms.
Well, they controlled for disturbed behavior in childhood, so they really, took a look at a lot of these things, but there are certain things that you just don't know about, that you can't control for, like genetic makeup and, things like that. So, however, also, these associations are backed up. Many of them are hypothesis driven, and that's really what brings. So we know that the cannabinoid receptors are very important for brain growth, particularly during adolescence. And what they do is they guide axons to the right connection. Okay, and marijuana just when you have marijuana on there, so that's kind of blocking your endogenous cannabinoids or overwhelming that system. The growth doesn't always happen properly, and that's thought to be the reason why we've seen increases in thought disorders in this group because something, the growth is not happening properly. So this is a healthy individual, okay? This is the corpus callosum in the brain. And this is a daily marijuana user, and the circle is here to show you that there's thinning of this part of the brain, okay? And by the way, that's the exact same thinning. I'm sorry, this is a little hard to see, and I myself am not a neuroscientist, but it's the exact same thinning. You'll have to, it's a little hard to see, but you'll have to believe that it's the exact same thinning that you see in patients with schizophrenia. So something is going on there. Oh, and this is the slide that I was missing. It's just in a different place. This is just showing you the risk of developing an alcohol use disorder. If you get drunk the first time before you're 13, it's nearly 50%. It's 9% if you wait. Same pattern with marijuana. So you can think of adolescence also as a critical period for developing addictions. And to flip that around, if you can get somebody through their adolescence, it's actually very unusual for an adult to develop a new onset addiction. All right, so that brings me to what we can do about it in primary care. Because I want to make the argument that there's a lot we can do and it's not so challenging. So I want to start with what I think is good news. So this is slides from survey data with pediatricians. This was done by the American Academy of Pediatrics. So in 1997, they sent a survey to their members and asked them, do you screen teens annually for substance use? And in 1997, less than half of them said, yeah, I screen. In 2007, we repeated the survey just in Massachusetts, and we got 86% of people saying yes, they screen. And then we repeated again nationally in 2013, and we saw similarly high numbers, about 90% people saying that they screen annually. So this really tells us that the culture has shifted. Screening is absolutely, at this point, considered a routine part of adolescent healthcare. It's considered a key component, something that you really have to do. Unfortunately, the practice hasn't really kept up with the attitudes, and I think that's why we're here today, right? So if we asked the same groups in 2007, 2013, how are you screening? Are you using a validated tool? And about a third or less of them were using a validated tool. And we followed up our quantitative survey actually with some qualitative work we called. We interviewed 24 pediatricians, and we asked them about their screening practices, and we heard over and over and over again quotes like this one saying, it's a very small city, I wouldn't think that kids are really using drugs and alcohol. And we heard this everywhere. I mean, we heard this, take out small city and put in, I know it's Manhattan, but I don't think kids are, I mean, we really, everywhere we went, this is what we heard. By the way, so this quote came from a doctor who was practicing in the state with the very highest rates of alcohol and marijuana use amongst the teens. So it's there. If it's not there, it's not because, if you're not finding it, it's not because it's not there. Here's another pediatrician saying, well, there hasn't really been agreement among physicians in my practice about the need for a screening tool on adolescent substance use. So it's not there, and if it is there, I'm going to find it. I don't need a screening tool. Unfortunately, though, the data just doesn't back that up. This is a study that was done by my colleague. It was back in 2004, but what she did was she was recruiting patients in the waiting room in an adolescent medicine program, and those patients were getting a complete psychodiagnostic interview. So she knew if they had substance use disorders. And then the kid would go see their doctor, and afterwards she would hand the doctor like just a one piece of paper and say, the kid you just saw, is he using drugs, and if so, does he have a problem or disorder or dependence? And you can see that for any use, the sensitivity for detecting use was about 63%. Not great, but not terrible. I think this included some urgent care visits where the docs really weren't asking, so it probably would have been a little higher had that not been the case. Not terrible. But if you ask them, well, was substance use associated with a problem, the sensitivity falls down to 14%, and for disorder, the sensitivity falls down to 10%, and for detecting dependence or addiction, it falls down to 0%. So,
And I'm sorry, that's compared, the criterion is the DSM-4 interview?
right, it was a complete psychodiagnostic interview. I forget, I think they did the CD-SAM or something. So So the sensitivity is really pretty interesting. Basically, the bottom line is, yeah, most of the time they knew when kids were abusing, but they had no idea how serious the use was. And here's a quote that really underlines that. This is from this recent survey that we did, this recent qualitative survey we did with pediatricians. This one said, well, if patients are drinking, it's like stupid high school kids who go out and have a couple of beers on a weekend here and there. It's not chronic alcohol problem. So this is what the Trevor case is built on, right? I mean, it's, well, it's just, you know, stupid high school stuff. It's not really serious. And our problem is that pediatricians, when they think that they're screening for this, right? And they're saying to us, I know when this kid comes in, I know she has a drug disorder. I don't need a screening tool because I already know. And by the way, nobody like this comes into my practice. And both of those sentiments are true, more or less, right? I mean, you know, kids like this tend not to get primary care. And if they do walk in, they're probably saying, I need help with a drug problem, and so they don't need a screen, right? Both of those are true. But that's actually not what we're looking for, because we know that these kids you don't find on screening. It's these kids that we want to look for, okay? So these are the kids doing stupid high school stuff who are really hurting themselves. And by the way, it's these kids who I think we could really impact in primary care. I mean, this kid needs specialized treatment. We're not going to really do too much in primary care, right? But these, we could do something. We could do something quickly, and we could do something, I would say, effectively.
Oh,
So-
there's the pyramid Cindy, Sandy.
Right, so... So this is the pyramid. So this is actually, so I don't know, different people have different versions of this pyramid. This is my version of it, and this is actually, what I've done is I've gone through the American Academy of Pediatrics recommended interventions for each level and based this on the DSM-5, right? So, you know, we have the non-users, right? And the kids who, I call them dabblers, because they use a little but they don't have a substance use disorder. So that's like really the large majority of this pyramid. And these kids, you can do something very, very positive for in primary care. Then you've got this group that's going to be really tricky because they've got mild to moderate substance use disorder. Their only chance of getting anything is in primary care. So you guys are going to be on the hook, but it's slightly more complicated. And then you've got these kids with severe substance use disorder who we're hoping you can just find in primary care and get connected with treatment. So about 3 years ago, NIDA put out a request for applications asking people if they wanted to design and test a screening tool. And so I got funding through this mechanism, and so my group did one of these research projects. And the story goes like this. We thought, well, we've got to make screening as simple as we can for clinicians because we know they're having a hard time doing it. And so really the way to do it is make it all electronic, right? We'll administer like not only a screen, but then a little assessment battery so that we can get these kids, onto the pyramid, and then they'll know what to do, right? It'll be pretty easy because they'll be just like right on the pyramid, and we'll say, okay, this kid has substance use, but no substance use disorder. Go ahead and do that intervention. And so we put together a questionnaire. It was like 15 questions. Kids did it pretty quickly. Most of them did it in under a minute, but it took a little sophisticated computer programming with skip patterns and all of that. And we analyzed the results, and it looked like it was pretty good, and we presented it back to the people at NIDA who had funded it, and they said, okay, that's very nice. Now what we want you to do is take your very first question, and this was the very first question. In the past year, how many times have you used tobacco, alcohol, or marijuana? And they had a multiple, so this is 3 questions, right? How many times have you used tobacco? And they had to say never, once or twice, monthly or weekly, and then repeated for alcohol and marijuana. And they said, we want you to look at these categories and see how well those categories by themselves map onto here. And so, you know, with all the hubris in the world, I thought, oh, that's silly. I mean, that's just like, how can we get all the information from one little question? But, you know, if you guys have had experience with research grants, when your project officer asks you to do something, generally you do it. And we're like, okay, we'll run the model, and we'll just see. Well, I mean, we ate our hat because it turned out that those 4 categories map perfectly onto the pyramid with sensitivity and specificity, you know, over 90%, which is just like absolutely stunningly remarkable. It was actually better than the long tool because the long tool used some questions that mix substances and we couldn't tell them apart. So just absolutely remarkable. And then we said, okay, this is what we should use as a screening tool because it's really easy to administer and we're going to know exactly where the kid sits on the pyramid. And so, and actually, so I apologize, it's a bit of an old slide. This is just referencing a presentation, but this was published last summer in the Journal of the American Academy, the JAMA Pediatrics. So it has been published in the peer review literature. All right, so now that I've got the kids onto the pyramid in their right group, so what intervention am I doing here? And so, again, you know, I'm a pragmatist. I know that you've got about 2 minutes to talk about substance use, especially in your low-risk kids where this is really not the key issue, is just one component of their health. And so, but I do believe that no matter, yes?
Just a quick question as far as getting them on the pyramid. So again, those algorithms as far as for sort of asking those 3 questions, deciding where they go on that, those are ones that are sort of, that we can use and can sort of, we have those as far
Already
as those
building,
algorithms?
yep.